Right, good morning, everybody. I'm Mai Stafford from the Health Foundation. So over the last couple of years, we've been doing some work looking at ethnic inequalities in healthcare, particularly focusing on people that have got long-term conditions and multiple conditions. And that's work that we've been doing with King's College London. Big thank you to all of my co-authors and also to all the patients who've allowed us to use their data. So based on systematic reviews and new analysis, we know that people from many minoritized ethnic groups have a higher prevalence of long-term conditions. So this is a figure from my colleagues in the Real Centre that shows higher levels of multiple long-term conditions in Black, Caribbean, Pakistani, Bangladeshi ethnic groups compared with white ethnic groups. And then you can also see some of the specific conditions that contribute to that. And much of the care that is provided for long-term conditions is led by general practices. And there are guidelines for the care of long-term conditions. And there are achievement measures that indicate whether that level of care has been provided. And the quality outcomes framework is an annual pay-for-performance scheme that resources and rewards practices based on those indicators or some of those indicators. So patients that have been diagnosed with one or more of these long-term conditions should be included in these indicators unless they have what's called a personalised care adjustment or used to be called an exemption from the QOF. And that excludes patients from the recording either to make sure that they're not being given inappropriate care or to make sure that practices are not being inappropriately penalised for factors outside of their control. So there are a number of different reasons why a patient might have a personalised care adjustment. And we're focusing on patients that were deemed unsuitable for treatment by the clinician or where the patient refuses treatment through informed dissent. And we focused on these because we think they might give insight into some of the clinical judgments that are going on and also some of the decisions or choice that patients might have. In practice, probably these two are not totally unrelated to each other, so there might be some misclassification in terms of what ends up getting recorded. So we know from previous studies that there are higher rates of informed dissent in practices that have got a high number of registered patients and that are more socioeconomically deprived. And we also know from existing studies that a patient is more likely to be deemed unsuitable if they're older, if they've got multiple long-term conditions, or if they live in a socioeconomically deprived area. But what we don't know yet from existing studies is how this looks across ethnic groups. So the existing studies, there's some that have used ecological design, sort of practice level QOF measures, or they focused on single clinical domains. And we wanted to take a look at this from a multiple long-term conditions perspective. So I'm looking right across the range of indicators. So we used routine GP data for this study. So the personalised care adjustments and ethnicity, they're recorded in SNOMED codes in the GP data. We used 2011 ethnic census categories for ethnicity. We used a clinical practice research data link, the ORAM version of that. And this was linked to hospital episode statistics, which allowed us to fill in some of the missing ethnicity data. Even so, I think there was about 5% of our eligible sample that had missing ethnicity, which is quite a common, well-known issue that that data can often be missing. So the people that were missing ethnicity, they tended to be younger and they tended to have fewer conditions. But they are missing from our analysis because we've done a complete case analysis. We also linked to the index of multiple deprivation as a proxy for the individual's socioeconomic circumstances. So we had a random sample of 690,000 adults at our baseline in January 2016. And of these, just over 250,000 had at least one condition and should have been included in the so these 250,000 people, they had a condition, one of the conditions at baseline on the 1st of January, and then we followed them up for up to 4 years to see whether they got any flag for an exemption or a personalised care adjustment. You can just see on the right-hand side, those were the conditions, the prevalence of the conditions. So asthma, depression and hypertension were the most commonly recorded QOF conditions that people had. So moving on to the results for the first kind of reason for exemption, which is informed assent. So just before I walk you through the models, just to say that women and older people were less likely to have informed assent, and people living in more socioeconomically deprived areas were more likely to have informed assent, as were people who had multiple conditions. So we did 3 models. One was just an age and sex adjusted model, which is the grey squares, model 1. And you can see that, so this figure on the right-hand side is showing the odds ratio, the likelihood of having an informed assent recorded in your GP data across the different ethnic groups. And it's relative to the white ethnic group, which is shown by the dotted line at 1. So most of the minoritized ethnic groups were less likely, to have informed assent recorded. And when we further adjusted for the number of conditions that people had, model 2, and then also the socioeconomic deprivation in their local area, model 3, it didn't make too much of a difference in the findings, really. So just thinking about this, without more qualitative understanding and in-depth understanding of what's really going on here is quite difficult to interpret. So that's definitely some kind of further work that needs to be done here. But does informed assent, does that capture, is that message supposed to be there? Oh, sorry. Does this capture non-compliance or non-adherence? And we've heard in some other contexts that there are racialized explanations for why people from some ethnic minorities refuse healthcare. And from these findings, there's no support for this in relation to the QOF. There's no evidence that people from ethnic minority groups were more often refusing treatment or not choosing to take GP recommended care. But maybe this informed assent actually indicates patient choice and empowerment. And we know that patient empowerment is important for improving patient experience of healthcare. And so maybe our results are actually suggesting that people in minoritized ethnic groups feel less able to disagree with the clinician or say that it's not in line with their wishes and what they want from their life. So that's certainly something that we need to probe in further work. And then moving on to the second reason that we looked at, and this is where the clinician deemed that the patient was unsuitable for the treatment. So from other evidence, we know that, from the models, we know that the likelihood of having this recorded is higher for people that are older and that live in more socioeconomically deprived areas. Also, that people with multiple conditions are more likely to be deemed unsuitable. So again, this is the same approach to modelling. Model 1's just age sex adjusted, model 2 adds the number of conditions, and model 3 adds socioeconomic deprivation. And you can see here a bit of a different picture. So relative to the white ethnic group, people from several ethnic minority groups were more likely to have patient unsuitable recorded in their data. There were quite wide confidence intervals, so quite a lot of that overlapped one there. But what we found here was that generally, then when you adjust for the number of conditions that people have and the socioeconomic deprivation in their local area, there's some attenuation. So it brings the ethnic minority groups more towards the white ethnic group. So patients might be deemed unsuitable because they're intolerant to therapy or they're already on the maximum dose, and there might be a risk of adverse events, for example. And the QOF guidelines, they are evidence-based, but they're not tailored to people's comorbidities or their social context. So that might explain what's going on here. And I guess this raises questions about how we're going to reduce inequalities in this being deemed unsuitable for treatment. And that really falls outside of what we were able to look at in this study. But we know from what other people have written and been talking about that people with multiple conditions are excluded from randomized controlled trials often. So, if we're able to get better evidence on people with multiple conditions being treated, then there would potentially be less of this needing to deem the patient unsuitable. We've also know that there's lots of initiatives within general practice to try and tackle some of these wider social determinants. So co-locating services to make it easier for people to use healthcare, increasing cultural understanding, these kinds of initiatives. So just finally, some limitations, I guess. We only counted the QOF conditions at baseline, so people might have acquired more conditions during follow-up. And we had fairly detailed ethnicity data, but we didn't disaggregate the white ethnic group because that would have led to more missing data. We have here focused on patient-level characteristics, but we know that practice-level factors are important as well. So just to note that personalised care adjustments, they are already used minimally and they're carefully monitored. So we're not suggesting that this is inappropriate use of these exclusions. But even so, we know that when patients are not included in these targets, there's potentially a risk that they are given less of a focus. And so this could perpetuate inequalities. And even where this is appropriate, we're still having, it still means that we're missing all this information on people because they're excluded from their monitoring. Thank you.